Assalamu alaikum. Good afternoon, everyone, and welcome to our academic activity for today. So today we have two lectures. The first one about surgical management of aortic valve endocarditis by Dr. Khulud from King Fahd Medical City, and the second lecture will be about management of surgical about mitral valve and tricuspid valve endocarditis by Dr. Afnan Al-Malki. So we'll start in 5 minutes. Thank you.
So can we start? We'll have Dr. Haytham with us today. Haytham, you're around? Haytham?
دكتورة خلود تفضلي وكان ستارت.
I'm just waiting for Haytham because he's the moderator. طيب. So my topic today is surgical treatment of aortic valve endocarditis. We talked about this topic before, about the disease and the pathogenesis, but we'll go over it quickly just to refresh your memory. And also last week we mentioned the guidelines, so I will not mention it here for when to operate. So we'll have a small introduction, and then we'll talk briefly about the epidemiology, then about the pathogenesis and the pathology, then about the microbiology and the clinical presentation of the patient and what you will see on the physical exam, the diagnosis and the treatment, and then finally the surgical treatment. So as an introduction, as you all know, infective endocarditis is a disease in which microorganism colonizes a focus on the heart, producing fever, heart murmur, splenomegaly, embolic manifestation, bacteremia or fungemia. And early diagnosis of this condition is extremely important because it leads to devastating complication and death if it's not treated with the antibiotic, combined with or without surgery. So the predisposing factors for the infective endocarditis are cardiac abnormalities that disrupt the endocardium by means of a jet injury, as well as the presence of a blood-borne microorganism that colonizes on these abnormal surfaces. So among patients who have these aortic valve endocarditis, usually the congenital bicuspid aortic valve is the most common predisposing lesion. But there are other predisposing lesions like degenerative calcific aortic stenosis, aortic insufficiency secondary to connective tissue disorder, and also rheumatic aortic valve disease. So depending on the virulence of the offending organism, normal aortic valve can also be affected. And the patients who have already a prosthetic heart valve, they have a constant risk for developing infective endocarditis throughout their years. The annual incidence of infective endocarditis is estimated to range 1.7 to 7 episodes per 100,000 persons in North America. And the patients with the prosthetic aortic valve are also reported to have incidence of infective endocarditis 0.2 to 1.4 episodes per 100 of patients' years. And it varies with the type of aortic valve. So approximately 1.4% of patients that are undergoing aortic valve replacements develop prosthetic valve endocarditis during the first postoperative year. And this is one of the causes. The other is the incidence of the nosocomial endocarditis is increasing because more patients undergo invasive procedures. These invasive procedures, like in hemodialysis patients, it's relatively infrequent, but it's associated with a high mortality. Also, dental extractions, they have been demonstrated to produce bacteremia. Also, they mentioned that dental flossing can produce bacteremia in periodontally healthy and periodontally diseased individual at a rate comparable to that of some dental treatments. So prophylactic antibiotic is usually given to prevent this. Also, other invasive procedures like endoscopic procedures, they can cause bacteremia. And IV drug abusers, they are particularly susceptible to infective endocarditis, and this occurs on a structurally normal heart valves. So for the pathogenesis and pathology, in 1928, the Grand and colleague, they theorized that platelet fibrin thrombi on the heart valve served as a nidus for bacteria adherence. And in 1963, Angrist and Oka, they introduced the term non-bacterial thrombotic endocarditis to describe the sterile vegetation on a heart valve and provide experimental animal evidence supporting the role of these vegetation in the pathogenesis of endocarditis. Experimental inoculation in animals with pre-existing non-bacterial thrombotic endocarditis produced by mechanical abrasion of the endothelial covering of the heart valves causes a promote leukocytic infiltration of the thrombi. And as the microorganism multiply, more leukocyte and thrombotic material accumulate in that area, and verrucous vegetation begin to form. Now, depending on the virulence of the organism, what is it? And we'll talk about it later, and the resistance of the host, the aortic valve can be destroyed and the infection may spread to the annulus and the surrounding structure and cause abscess formation. Then after, the abscess can rupture into the pericardial or the cardiac cavity. So infective endocarditis is not only it doesn't only cause destruction of the aortic cusps, but it also causes paravalvular abscess, cardiac fistulas, and also cause coronary and systemic embolization of the vegetations itself. Cerebral infarction can be either ischemic because of arterial occlusion or hemorrhagic because of rupture of the mycotic aneurysm is common in these patients. The mycotic aneurysm, the infarcts and the abscesses of other organs such as spleen, liver, kidney, and limbs are also common. And aortic valve endocarditis with a large vegetation that prolapses into the left ventricle and comes in contact with the anterior leaflet of the mitral valve can cause secondary involvement of this valve. That was for the native. For the infection of the mechanical valve is also present, and it's located usually in the sewing ring. Also, infection of a porcine or pericardial valve may involve the cusps, the sewing ring, or both. And the infection of the aortic valve homograft that's been done before and pulmonary autograft resembles that of the native aortic valve. It begins in the cusps and destroys them, then causing aortic insufficiency, but it can also extend to the surrounding structure. Endocarditis after aortic root replacement and mechanical valves frequently causes dehiscence of the valve from the aortic annulus and consequent false aneurysm. So what is the microbiology of this disease? The microbiology of the infective endocarditis of the aortic valve depends on whether the valve is native or prosthetic, and whether the infection is hospital and or community acquired, and we'll talk about each one. So Staph Aureus and Strep viridans are the most common microorganism responsible for native aortic valve. Staph aureus is extremely virulent and is able to cause infection in patients with a normal aortic valve. Strep viridans is not as virulent, but causes an infection, often followed by a protracted course. Also, we have Staph epidermidis and various other streptococci can also cause endocarditis. We have also coagulase negative staphylococci that have emerged as an important cause of native valve endocarditis in both the community and the healthcare system. Endocarditis caused by gram-negative bacteria is uncommon, but it's often resistant to antibiotic therapy and may cause serious complication. We have also the HAC group, which is the Haemophilus, the Acinobacillus, the Cardiobacterium, the Cannular, and the Shigella. They're gram-negative bacilli grouped together, and because of their characteristic fastidiousness, it's requiring a prolonged incubation period before growth, but this type is uncommon. And lastly, the fungal endocarditis, it's rare, but it's extremely serious, and it's usually caused by Candida and Aspergillus. Then for the microbiology of the prosthetic valve endocarditis, it's somewhat different from the native. The prosthetic valve endocarditis is classified as early when it occurs within 2 months after surgery, and late if it occurs after 2 months. However, it is possible that many cases of prosthetic valve endocarditis occurring during the first year after surgery are acquired at the time of implantation of the artificial valve. And this may be particularly true when the infection is caused by the coagulase negative group and the HAC group. So early prosthetic valve endocarditis is caused by contamination of the valve at the time of implantation, and we'll talk later how to try to avoid this in the surgical treatment. Staphylococcus epidermidis, Staph aureus, and Enterococcus faecalis are among the more common microorganisms responsible for early prosthetic valve. And the sources of late prosthetic valve endocarditis are more difficult to determine. Bacteremia is probably the principal cause of late endocarditis. Although streptococci and staph are commonly encountered in these patients, usually or sometimes a mild rate of microorganism can cause late prosthetic valve endocarditis. Nosocomial infections are caused again by Staph aureus and Staphylococci. They mentioned also that in a small portion of cases of the aortic valve endocarditis, no organism can be cultured from either the blood or the surgical specimen. This is called the culture-negative endocarditis, but it's important to rule out these fastidious microorganisms, and every effort should be made to identify them. So what are the clinical presentation of these patients? First, it's helpful to classify whether the infective endocarditis is acute or subacute, because there are major differences between these two clinical presentations. In the subacute, it's often caused by a less virulent organism, like we said, the Staph aureus. When this organism affects the diseased aortic valve, the clinical course is protracted, and antibiotic alone can cure most cases. But on the other hand, the acute endocarditis, it's frequently caused by virulent microorganism, like we said, Staph aureus, and may affect the normal aortic valve. The clinical course of this the acute endocarditis is acute, and antibiotic alone often fail to cure the infection. So the onset of the subacute endocarditis in most cases is subtle with low-grade fever and malaise. The patients usually they come and they think they have the flu, and once they get the oral antibiotic for about 1 week to 10 days, their symptoms improve. But in most of these cases, the symptoms reoccur a few days after stopping the antibiotic. In these patients, usually an aortic valve murmur is present in nearly all patients. Splenomegaly is common. You can see clubbing in the fingers and toes in very long-standing cases. And the skin and mucous membrane sign occur late in the form of endocarditis. Also, you can see petechiae over appear of any part of the body. Small areas of hemorrhage may be seen in the ocular fundi. As you all know, the splinter hemorrhage, which is the linear distribution in the distal end of the nail. Also, the ossular nodes. The ossular nodes, they're acute, tender, barely palpable nodule lesions. Usually, they're on the tip of the fingers and toes, and the bacteria can be cultured from these lesions. Embolization of large vegetation fragments may cause dramatical clinical evidence, such as acute MI, stroke, splenic, or hepatic infarct. So any organ in the body may also be involved. For the physical signs, two physical signs are only seen in the acute endocarditis. As you all know, the Janeway lesion. The Janeway lesion, it's a painless red-blue hemorrhagic lesion, and it's found in the palm of the hand and the sole of the feet. Then the Roth spot, it's an oval pale area surrounded by hemorrhage near the optic disc. You can see here in the pictures, here you can see the Roth spots, the white spots surrounded by the hemorrhage, the ossular node on the palm, on the fingertips, the Janeway lesion on the palm, and the splinter hemorrhage, which is at the distal end of the nail bed. Here you can also see the infective endocarditis on the valve itself, here on the native valve, and here on the excised valves taken out because of this large vegetations. So how to diagnose this infective endocarditis? Usually, as you all know, Doppler echo is very useful in diagnosis and management. TEE is usually better than transthoracic, and multiplane is better than monoplane for the diagnosis of endocarditis. You can see on the echo, it can detect vegetation as small as 1 or 2 millimeter in size, but it's more reliable in native than prosthetic valve endocarditis. It's more useful for tissue than mechanical valves because of the acoustic shadowing of a ball or a disc or leaflet motion of the mechanical valves. Also, the echo is highly sensitive for detecting the perivalvular abscess and the cardiac fistulas. So for the diagnosis, also we have the modified Duke criteria that's mentioned in the book. There are some major and minor criteria, and depending on the criteria, you'll have either a definite diagnosis or possible endocarditis. So for the major criteria, We have blood culture positive for infective endocarditis. And we said about the organisms depending on which type. Here they mentioned like the staph and the strep, everything I mentioned before. Also, at least 2 positive cultures of blood drawn more than 12 hours apart, or all of these 3, or majority of more than 4 separate blood cultures. You can, if you have a single positive blood culture for Coxella bronchi, then it's another major criteria is evidence of endocardial involvement. Like on the echo, you can see it's recommended, and you can see it by clinical criteria. Then you see oscillating intracardiac mass on the valve or the supporting structure, the path of the regurgitant jet, or the implanted material in the absence of any alternate anatomical explanation. You can see the abscesses in the echo, and if there is a dehiscence of the prosthetic valve. Another major criteria is new valve regurgitation or worsening, or changing of pre-existing murmur. The minor criteria, if there is a predisposition to the disease itself, predisposition, heart condition, or the patient is an IV drug abuser. Fever, vascular phenomena, like we mentioned, major arterial emboli, septic pulmonary infarct, mycotic aneurysm, intracranial hemorrhage, the conjunctival hemorrhage, and Janeway lesion. Immunological phenomena like glomerulonephritis, ocular node, Roth spot, and rheumatoid factor. And microbiological evidence, positive blood culture, but does not meet the major criteria, as we said above. And for the definitive endocarditis, you need 2 major criteria, or 1 major and 3 minor, or 5 minor criteria. For if it's a possible endocarditis, 1 major plus 1 minor, or 3 minor criteria. So what is the treatment of infective endocarditis? An appropriate antibiotic is the most important aspect of the management of patients with infective endocarditis. Antibiotic therapy should be started soon after obtaining several blood cultures, and the initial choice of antibiotic is based on the clinical circumstance and the suspected source of infection. Patients who have had recent dental work should receive antibiotic to counteract the bacteria from the oral cavity. Those who had recent urinary or colonic procedures should be treated with antibiotics that are effective against gram-negative bacteria. And intravenous drug users are usually infected with Staph aureus or coagulase-negative staphylococci, and antibiotics should be chosen accordingly. Once the marker organism is identified by the blood culture and its sensitivity to specific antibiotic is known, the antibiotic therapy is adjusted according to the sensitivity. A combination of 2 or 3 antibiotics that potentiate each other is often needed in the treatment of endocarditis that's caused by a virulent organism. And the antibiotic therapy duration is usually continued for 6 weeks. It's difficult to eradicate infection caused by virulent organism with antibiotics alone, because usually these microorganisms often destroy the native aortic valve very rapidly, and they cause aortic insufficiency and complete heart block. These infections usually caused by Staph aureus, Pseudomonas aeruginosa, Serratia, or fungus infection. Surveillance blood culture are performed in 48 hours to monitor the efficacy of the antibiotic, and the patient must be watched closely for signs of complete heart block, coronary and systemic embolization, and persistent infection. Daily electrocardiogram and frequent echoes are performed during the first 2 weeks of treatment, just to see if the patient is improving or not. So with any evidence of increasing aortic insufficiency, enlarging vegetation, recurrent embolism, paravalvular abscess, or persistent infection, then this time surgery should be immediately performed. You shouldn't wait. It's important to operate on these patients before they developed intractable heart failure, cardiogenic or septic shock, or extensive root abscess that will make your surgery even more complicated. Patients with vegetations larger than 10 millimeter present a clinical problem because they're most likely to develop serious complication, and early surgery is justifiable. For the anticoagulation, actually anticoagulation is not effective in preventing the embolization of vegetation in the native and biological valves, and it's associated with an increased risk of neurological complication. Surgical treatments should be considered in patients with signs of complete heart block, acute valve dysfunction, paravalvular abscess, or cardiac fistula. Also with recurrent systemic embolization when the aortic vegetations are present, and persistent sepsis despite you giving the adequate antibiotic therapy for more than 4 to 5 days. Patients with neurological deficits should have CT or MRI performed to determine if the cerebrovascular, if the CVA that he got is ischemic or hemorrhagic. Because ischemic damage is more common than hemorrhagic damage, but they both are associated with increased mortality and morbidity. Mycotic aneurysms should be treated before valve surgery, and the aortic valve replacement should be postponed for 2 weeks after an ischemic stroke and 4 weeks after the hemorrhagic stroke, if it's possible. So moving to the surgical treatment, patients who need surgery are often, they're very sick and they can be in complete heart block. And for this reason, because they often require complex and long surgical procedure, myocardial protection is very important. And another important aspect of the surgery for endocarditis is avoidance of contamination of the surgical field instruments, drapes, and gloves with vegetation and pus. So instruments used and in the contaminated area in the heart should be discarded before reconstruction of the ventricle and the aortic begins. Also, the local drapes, the suction equipment, and surgical gloves should be all changed. When the infection is limited to the cusps of the native aortic valve or bioprosthetic valve, complete removal of the valve and implantation of a biological or mechanical valve usually resolve the sparkling. They mentioned that there is no evidence that bioprostheses are better than mechanical valves in patients with active infective endocarditis in the form of removing. Some investigators believe that aortic valve homograft is ideal for the patients with active endocarditis, but the fact is that it can become infected like other valves, and there is no evidence that the risk of persistent or recurrent infection is different from other valves. So median stenotomy is done.
Dr. Khulud, kindly go back. So what is the summary of this slide from your point of view?
What I understood from what they want to say that there is no difference between the bioprostheses and the mechanical valves with patients who have who currently have the active infective endocarditis.
And what's about the stentless or what like homograft?
They said that the homograft is ideal in the active endocarditis, but they said, but some of them said no, there is no difference.
Okay, because here, and there is no evidence that the risk of persistent or recurrent infection is different from other valve regarding a homograft or what they call it a stentless bioprosthesis as a general name. Actually, there is evidence. There is evidence. It is actually a series. There is one series was published recently, I think in 2017 or 18. I will send it in the group. That the homograft or stentless bioprosthesis is better, but the problem is availability, especially with the complicated infective endocarditis on the aortic valve. I think you will speak on that later on when you speak about surgical technique, right? Because there is simple aortic valve infective endocarditis and also complicated aortic valve infective endocarditis. So later you will speak about this surgical management for it, right?
I will talk about the surgical, but I don't have anything regarding the stentless and what is the study that you have. I didn't find anything about that. What they mentioned in the study?
I will send it now to the group.
Okay.
Just continue, then we can comments, and also there is, I believe, Dr. Claudio, I think, also with us, and Dr. Farid, so they have more experience with these. But I will send the study now in the group, then later we can discuss this.
Okay, sure.
I do agree with you. I do agree with you. There's clear evidence that in complex aortic endocarditis, stentless and especially homograft are the procedure of choice. If you can do that, that's especially if you have root abscesses, that's the main indication for homografts. So, but for the standard, well, I do agree that there are no differences for non-complicated aortic valve endocarditis. I do agree with you.
Thank you, Dr. Claudio. You can kindly continue, Khulud, but because when I saw here, it's written, there is no, the statement, yes, and there is no evidence that the risk. So kindly continue.
Okay. Median sternotomy is done. Intraoperative, of course, is needed, and you do a transverse aortotomy 1 centimeter or above the RCA. If the infection is limited to the cusps, then a removal and replace or repair of the native valve is used. If you're repairing, you can use the autologous pericardium. Otherwise, removal and replacement is done. If the infection is invasive beyond the leaflet, then resection of all infected tissue and the foreign material, the prosthesis, the pledget, and sutures are removed, and then reconstruction is done. Some surgeons, they favor the pulmonary autograft, particularly in young patients. If the aortic annulus is involved in the infective process, resection of the necrotic or inflamed area is needed before the prosthetic valve can be implanted. The defect created by the resection should be patched before a prosthetic valve is implanted. They mentioned they prefer the fresh autologous pericardium to patch small defects that are like 1 or 2 centimeter wide in the aortic root and the LVOT, and they use the bovine pericardium for larger defects that need repairing. Also, some surgeons, they use the Dacron fabric to reconstruct the aortic root. And here again, the aortic valve homograft is believed to be ideal for reconstruction of the aortic root and LVOT. The mitral valve of the aortic valve homograft can be used to patch the defects in the LVOT by correctly orienting the homograft. However, an aortic valve homograft is by no means a substitute for the radical resection of all infected tissue, because the persistent infection can occur even with this biological valve. The pulmonary autograft has also been used in cases of extensive destruction of the aortic root, but again, this valve is no substitute for the radical resection of all infected tissue. Surgery for the aortic root abscess and/or the cardiac fistulas is quite challenging. The most important aspect of this surgical treatment is radical resection of all infected tissue. They said, we believe that the type of valve implanted is less important than the complete expiration of the infected and edematous tissue. These patients frequently require replacement of the entire aortic root and reconstruction of the surrounding structure that also been involved in the abscess itself. But these operations, they're individualized because the pathology of the aortic root abscess is variable. Extensive resection and reconstruction may be needed. So patching of the interventricular septum, dome of the left atrium, intervalvular fibrous body, the right atrium, and pulmonary artery may be necessary, as well as repair of the left and/or right coronary arteries. The aortic root is often replaced with a valved conduit. Aortic root abscess extending into the intervalvular fibrous body or into the prosthetic mitral valve is difficult to treat, and in these cases, the resection and reconstruction can be performed through the aortic root and the dome of the atrium. When an aortic valve homograft is used for this type of reconstruction, the anterior leaflet of the mitral valve of the homograft can be used as a patch material for the new fibrous body between the aortic and the mitral valve. Here you can see the mechanical prosthetic endocarditis. You can see here the prosthesis and the sewing ring and how the vegetation is attached to the whole sewing ring. And after they removed it, the vegetations were present below and above in that area. Here, this is actually a fungal infection, and they mentioned that it's rare, but it's very bad disease. You can see here how the valve is destroyed. So usually also these patients, the postoperative complication that's common after the surgery of active infective endocarditis, because septic patients, they may have severe coagulopathy and they may bleed excessively after the cardiopulmonary bypass. Antifibrinolytic agents such as tranexamic acid, aminocaproic acid should be used in addition to the platelets, the cryoprecipitate, and FFP in the patients with coagulopathy. Also, you can use the recombinant factor 7 can be used for the correction of the thrombocytopenia for the fibrinogen level and thromboplastin and prothrombin time. And if you do a radical resection of the aortic root abscess, it may cause a heart block, and this patient will later need a permanent pacemaker post-op. So depending on the patient's clinical condition before surgery, multi-organ failure may develop post-op. Usually neurological deterioration may occur in patients who already before the OR had pre-existing cerebral emboli, pulmonary, splenic, hepatic, and other metastatic abscess. Some of them require surgical treatment. And large metastatic abscesses may be have to be drained in the case if it's in the spleen. Splenectomy should be performed because of the risk of rupture. So what is the prognosis of this disease? It depends largely on the disease when it's diagnosed and what is the organism that is found and how it's treated. Patients with a prosthetic aortic valve endocarditis have a more serious prognosis than patients who come with a native aortic valve endocarditis. And nosocomial infection are associated with a higher mortality than the ones with the community-acquired infection. The results of surgery for infective endocarditis have improved significantly since the introduction of antibiotics and surgery, but the in-hospital mortality rate is still high and it reaches approximately 18%. The prosthetic valve endocarditis, increasing age, pulmonary edema, the infection that's caused by Staph Aureus or coagulase negative staphylococcal infection, patients who have a mitral valve vegetation and who have a paravalvular abscess, they're all associated with the increase of in-hospital mortality. The operative mortality for the patients with the infection that is limited to the cusps of the aortic valve is dependent on the clinical presentation of the patient at the time of surgery and the age and the comorbidity. Most reports, they indicate that the operative mortality is under 10%, and the operative mortality is higher if it's a prosthetic valve endocarditis, and it ranges from 20 to 30. Similarly, the more complex the surgery, the higher the mortality. The surgery for the aortic root abscess is associated with a higher operative mortality. Here they mentioned a graph in the book for the survival of the left-sided infective endocarditis, if it's aortic, mitral, or both. And you can see the survival over the years. The more there's more infection, more valves, more infection, mortality will be higher, and among the years, I mean. So my reference is from Lawrence. Thank you very much.
Thank you, Khulud, for such a nice overview and presentation. Haytham, just a question about the study you sent. It did study the stentless bioprosthesis, I think, of a xenograft origin. I don't think it's, I'm not sure, did it study a homograft, a human graft? وده
Yes,
fresh
yes,
يعني
it's been mentioned, or read the details, you will see that homograft is under stentless bioprosthesis. Like solo valve, for example, it's called the stentless solo valve, which is manufactured.
Yeah. Can I make a comment on?
Of course.
Yeah, the study is about a specific valve which is has been introduced by Medtronic. It is called the freestyle. The freestyle is practically a xenograft, is a porcine xenograft, and the technical implantation and the concept behind this is definitely the same as the homograft. You can consider the same things, homograft or the stentless. The other valve, the solo that was mentioned, no, there is no indication for the solo unless you have just the leaflet endocarditis, because the solo is just leaflet. I had some experience with the solo. It is an excellent good valve. I don't know whether it's still on the market, but no, cannot be used for extensive reconstruction. It's just for the leaflet, and the technical implantation is the suturing the leaflet in place, and is the freehand homograft is not a homograft at all. Cannot be compared. And I have one point to stress with all the trainees in the presentation, that there was no much attention to embolism, vegetation, and kind of organism that may guide you in timing of indication, which is in a way everyday's life. The size of the vegetation is important, the kind of organism is important, but you can do that job with yourself, and see whether what is the size, larger vegetation, small vegetation, location of the vegetation, and kind of organism involved that can dictate the urgency or emergency in this kind of surgery. Okay.
I have doubt about what Haytham have mentioned about the use of such an article. I'm going to start first looking at the first statement in that article, that it is still debatable whichever substitute you have. And the numbers of this article is not good. Can you elaborate more, Haytham, on all the negative points you saw in that article?
Yes, there is a lot of debates, especially about this topic. Even this article, one of the things is a retrospective analysis of the data.
So retrospective is an issue.
Yes, and I just brought it.
What else do you see negative points in this article? The thing I want you to emphasize, especially for our younger surgeons, is that the matter is still debatable, and you cannot rely on one article here and say it is the way, especially if it has so many negative points. I do have my preference, but I don't want to project that on everybody else's. So you have to realize, and this is for the juniors, you have to realize there is a debate, a big debate on this issue. Many people have different preferences. There can be sharply different between surgeons, but it doesn't, so far, there's no evidence one is better than the others that have cut the answer clear enough for everybody. Okay?
Yes, totally agree, Dr. Farid. And this article is not to prove that using homograft or stentless bioprosthesis is better than, but when I saw the statement that there is no evidence supporting that, no, it is debatable. And why I bring this article, just to show there is some evidence. It is weak evidence, but there is some evidence, and there is also other articles. It's all retrospective analysis. And the problem also with the homograft, if we are just speaking about homograft, not the freestyle, the availability of the homograft. Yani, for example, in Saudi Arabia, like King Faisal, they have the capability to have the homograft, but not all the hospital. What I want, yani why my intention to bring this article, not to prove superiority, but to bring that there is other evidence. So we cannot say there is no evidence. There is, it is weak, but there is another option and it still is debatable, and there is no clinical trial or a big series showing superiority for one methods in compared to the other methods. And in simple infective endocarditis, even latest recommendations, all the same. I mean, in the guideline, you can use all the things. This is only for complicated one. Some of these studies showing better outcome with it.
Well, I still side with Khulud's statement. When I say in my presentation, no evidence, I mean no convincing, strong evidence for everybody to follow. And that's why the controversy is still there. Yes, if you want to find evidence, you can find evidence for everything in life. And you just dig around and you find somebody, some stupid surgeon somewhere have written something about something bad. And but it doesn't mean it's an evidence. Bad evidence is no evidence. Okay. I'm sorry to be so abrupt, but I think it's very important for everybody to realize that it is debatable. And the statement that we expect you to know is that there's no difference between any of the valves so far to sway the whole surgical community to go one way or another.
Even kindly, Dr. Farid, even for complicated aortic valve infective endocarditis, the same statement?
For any pathology, period. I think it's easier for me to handle the bad annulus, the destructed annulus, if I use a homograft, but it doesn't mean it's an evidence. It's my preference. It's easier for me. I can handle it better, yes. But if you are, if you have used patches, if you know how to reconstruct the annulus, if you are expert with the commando procedure, all these things are come handy. It doesn't mean it's evidence.
Yeah, I do agree with Farid. I mean, he is an excellent, all-rounded, experienced surgeon. He can deal with adult and pediatric, and especially for this, he can easily work with the homograft, which is not the case for most of the adult cardiac surgeons, because homograft is not part of their training, as at least extensively, I mean. So you got patches and you got valves, and the point is to resect all the infected tissue. And this was clearly pointed out in the presentation, I have to say. Yes. The goal is removal of all the infected tissue. That's the point, the main point. Then you can reconstruct what you have, the hole in the left atrial roof and the aortic mitral membrane. You can close with a patch, and then you can put a bioprosthesis. You can put a mechanical valve on it. It is a very complex operation, and those who can master the homograft can do easy. But if you don't have that training, you can do with patch and prosthesis, and there is no evidence that there are different results. No.
If I just add one point about the homografts, the issue is also with the homografts at the time of redo. The homograft will be when the patient come after long time.
Oh yeah, yes, yeah, that's another issue. But
yeah.
It's not everybody cup of tea, as the British say.
Yeah, and also the cardiologists, they don't have enough experience with the TAVI inside a homograft.
No.
Until now. Yeah.
That's another issue, but it's a way far beyond, I think the scope of this presentation. TAVI in homographs. Okay, it is an extra mile.
Thank you, Dr. Farid. Thank you, Dr. Claudio, for clarification.
Okay, thank you, Dr. Farid, Dr. Claudio, and Haytham for your inputs.
Okay, thank you, everyone. So we'll have a quick break for 10 minutes and we'll start with the second lecture. Dr. Afnan.
Assalamu alaikum.
Alaikum salam wa rahmatullah. You can start.
All right. Thank you, Dai. Good afternoon, everyone. Speaking is Afnan Al-Malki, cardiac surgery resident from King Abdullah Medical City. The moderator for this session is supposed to be Dr. Shabir, but I believe he's still in the surgery right now. He said whenever he has the time, he's going to come and join in. So the lecture for today is going to be about surgical management for mitral and tricuspid valve infective endocarditis. Okay. So before I begin on my talk, I was lucky enough that I was on call yesterday when I received a call at around 6:30 in the morning with a case of a 57-year-old male, hypertensive, end-stage renal disease on hemodialysis, congestive heart failure with an ejection fraction of 30, known case of infective endocarditis, and he was operated back in 2019. Prosthetic valve at the aortic and mitral and tricuspid repair. The patient was admitted to the ICU as a case of non-STEMI and cardiogenic shock on inotropic support, dopamine, and noradrenaline. Suddenly, he developed progressive lactic acidosis and hyperkalemia. CRRT was initiated. When I saw the patient, vitally, he was febrile, 38.8 temperature and heart rate ranging between 120 to 117 beats per minute. Blood pressure systolic was 85. So we requested an urgent echo. Sorry. And it shows there is a stuck mitral valve and a new vegetation at the aortic valve measuring around 2.2 by 1.4 centimeter. There is another vegetation at the tricuspid valve. The measurement was 1.9 by 1.3 at the septal leaflet of the tricuspid valve. So keeping in mind that the patient was hemodynamically unstable, the decision to take the patient for emergency was not right at that time. So the next best option was to go with veno-arterial ECMO. Again, I was post-call and did not have the time to go through the literature to support that statement, but what I found out that ECMO is a valuable form of life support that should be considered in order to stabilize a patient until definitive surgical management is achieved. There is few and scanty evidence in the literature that concerning the use of ECMO in the context of an active infective endocarditis. However, the last statement said that short-term ECMO can be considered in mechanical support in a case of infective endocarditis in some sort of selective population. Now back to the objectives. I think Dr. Khouroudi did an amazing job explaining the pathophysiology, the causative agents, and all the clinical symptoms and presentation. I'm going to focus mainly on a brief introduction, and I'm going to go through the guidelines throughout the slides and focus mainly on the surgical approach for mitral and tricuspid. Native valve infective endocarditis is furthermore classified into right-sided and left-sided, and the most common predisposing valve at the left side is degenerative mitral valve associated with mitral regurgitation, which counts for about 40 to 45% of the cases. For right-sided infective endocarditis, especially involving the tricuspid valve, because in case of the pulmonic valve, it's rarely to get infected with infective endocarditis. The most common risk factors for the right-sided infective endocarditis, that would be intravenous drug abuse, as it has been mentioned before, indwelling lines, or in the recent era, that would be cardiac devices. Vegetations are primarily the manifestation for infective endocarditis, and they do have the tendency to stuck into the leaflets. They can also be found at the chordae, and they like to be on the lower pressure side of the valve, where the blood flow strikes and around the valve surface. As we all know that antibiotics can eliminate sensitive organisms in the blood, but they cannot penetrate the vegetation, the abscesses, or the prosthetic material. Therefore, delaying the surgery can potentially increase the risk for developing either local or systemic complications such as septic embolization, valve tissue destruction, or an invasion of paravalvular structures. Timing of the surgery, what I noticed recently is that it varies from one person to the other, and it can be divided into emergency, urgency, or elective during the same day of admission. What counts for emergency is having a native or prosthetic valve infective endocarditis with severe congestive heart failure, or the patient is a cardiogenic shock, hence our patient, or having an acute valvular regurgitation with severe prosthetic dysfunction. A fistulation into a cardiac chamber or any pericardial space. You can have your patient taken urgently if you have native or prosthetic valve infective endocarditis with persistent congestive heart failure, any signs of poor hemodynamic tolerance and abscesses. If the prosthetic valve endocarditis is caused by Staph Aureus or any other gram-negative organisms, if we happen to have a large vegetation of more than 10 millimeter and there is an embolic event or any other complication during the course, if we have very large vegetation, more than 15 millimeter in diameter, or if we have a large abscess or periannular involvement with an uncontrolled infection. You can have your patient taken electively if you have severe mitral or aortic regurgitation with congestive heart failure, but there is good response to antibiotic therapy, or if you have a prosthetic valve endocarditis with valvular dehiscence or congestive heart failure, but the patient is responding very well to the medical therapy. Or in case if you have an ongoing infection after excluding any other cause for extracardiac reason for the infection. So say we have this patient who's been diagnosed with infective endocarditis, referral to ID is made and antibiotics is initiated. The decision by the heart valve team is made, and what led to that decision is having a valve dysfunction causing heart failure or infective endocarditis caused by Staph Aureus or fungal infection or any other highly resistant organism. Having the case complicated by heart block or an annular or aortic abscess or any other penetrating lesions. If we have persistent infection, bacteremia or fever of more than 5 days and the patient is already covered on antibiotics, and that's class 1 for early surgery. Another scenario would be having recurrent emboli or persistent vegetation and the patient is already covered on antibiotics, that's class 2A for early surgery. Having a large vegetation of more than 10 millimeter, that's class 2B for early surgery. You can give your patient a little bit of time, as in more than 4 weeks, and that's class 2B if the patient has a major ischemic stroke or an intracranial hemorrhage. Here's another I'd say algorithm that specify when do we take for emergency and elective and urgency, and it's basically what I just said in the previous slides. So generally the aim of the surgery is to prevent any additional embolic event, and the surgery itself revolves around debridement, removal of all the infected tissues and the foreign materials, and restoring the functionality of the valve and keeping the cardiac integrity. Infective endocarditis can also be classified into simple or advanced. If the infection is confined to the valve cusp or the leaflet, then we're going to refer to it as a simple infective endocarditis of the native valve. Repair, replacement with either biological or mechanical valve according to the same principle that we followed for a non-infective valve. What counts for an advanced pathology, if we have an extravascular invasion beyond the cusp or the leaflets, then radical debridement and reconstruction is mandatory at this case. General principles, having TE intraoperatively is class 1B, and the operation for infective endocarditis are best performed throughout full median sternotomy, and that's class 1C. Debridement and removal of all the infective tissue with foreign material, that's class 1B. Enough with the general terms, let's get a little bit into specifics, talking about the mitral valve endocarditis. So we've already talked about the TEE and the exposure. What you may want to do next is that you want to cannulate your ascending aorta the normal way in the right atrium using bicable cannulation, including a right angle at the superior vena cava and a straight or right angle at the inferior vena cava. Antegrade cardioplagia, and for me, I chose one of the most common exposures for the mitral, which is throughout the left ichiotomy, throughout the Sondergaard's groove. So basically, you're done with your median sternotomy. You did your pericardiotomy. You started your bypass. What you may want to do next is that you want to take your venous cannulation and then lay them over towards your assistant side or to the left side, and this will help exposing this Sondergaard's groove better. Some surgeons love to think of the right atrium as a superior structure, and the left atrium will be the inferior structure. And this dotted line here, that would represent where would you place your incision. With diathermy in your hand on a low voltage, you want to start developing this groove approximately 2 to 3 centimeters away from the right superior pulmonary vein, and then go all the way down to like a few centimeters below the right inferior pulmonary vein. What you may want to do next is that carry out your incision with scissors, leaving around 1 centimeter area far away from the superior pulmonary vein and inferior pulmonary vein to avoid any injury to these structures. What's going to happen next is that you may want to ask your assistant to retract the anterior portion of the left atrium, and then your exposure would look something like this. Before you immediately go into the vegetation, you have to take your time inspecting your annulus, the full diameter, and then look at the anterior leaflet, the posterior leaflet with a nerve hook in your hand. Try to inspect the chordae tendineae for any tissue that may look edematous, inflamed, necrotic, simply not healthy. So this vegetation here on the posterior leaflet with its annulus is spotted. So what's going to happen next, as we said, the principle is always the same. You want to get rid of all the infected tissue, the vegetation, debride, irrigate, suction, make sure that your ground is clean, and then you can either decide to repair or replace. So in this case here, the resection of the vegetation is made, the debridement of the posterior leaflet with the annulus is made. When you try to generously debride the area that you think is infected and necrotic, in the same time, keep in mind that if the area looks non-infected, then leave it unbothered, because you want to maintain and preserve the integrity of the valve. So yeah, the posterior leaflet with the annulus has been excised. What's going to happen next is that we're going to move forward to the anterior leaflet, excise it, leaving around 3 to 5 millimeter diameter or rim to anchor the new valve that we want to deploy. What's going to happen next is, the created defect or the cavity that we caused after removal of the annulus, you may want to irrigate it, suction it, and make sure that it's clean. Afterwards, you're going to have to seal this defect with a pericardial patch. The way you fashion it has to be bigger than the defect you created, and then you start your sutures at the innermost part in the left ventricle, and then work your way either anti-clockwise and clockwise, and then meet somewhere in the middle. According to the guidelines, when the valve replacement is required, meaning that the first line in treatment in your mind should always be repair unless replacement is indicated. So prosthetic valve or mechanical valve are both acceptable unless there are some contraindications for the mechanical valve, such as intracranial bleeding. Then the choice to go with is the tissue valve. So what are you going to do next after you place your pericardial patch? You're going to start placing your pleated sutures around the annulus, and then pass the sutures onto the valve that you want to deploy. Make sure that you test your valve one more time before you do your final aortotomy closure. Okay, is it clear so far?
Yes, Doctor.
All right, thank you. Another option we have is when we have to repair the valve. Say you have a small vegetations that are healed, small, discrete, and they do not involve a major portion of the tensor apparatus. What you may want to do simply is just excise the vegetation, irrigate, deprive, patch it, and just leave the rest of the valve intact. And this is what happened here. We used to have a vegetation here, excised, removed, deprived, suctioned, and then we formed the patch the same way we did before, larger than the defect, with continuous praline sutures around the remaining part of the anterior mitral leaflet. And then what you may want to do next is that you want to support your repair by placing an annulus around the mitral valve. So mitral valve repair is class 1B indication for infective endocarditis. Unless the repair is not indicated, then you're going to go for the replacement. One more thing, if you have vegetation at the anterior mitral leaflet, there is always or almost always another kissing lesion at the aortic valve, and then the aortic valve should be also investigated. So when mitral endocarditis is presented, the possibility of concomitant aortic vegetation should also be considered. So we covered the simple infective endocarditis. Now we're going to move into the advanced one as it goes beyond the leaflet, the cusp. And I chose the posterior annular abscess, or it can be a circumferential annular abscess. The approach is the same. So when the annulus is destructed or there is an invasion, the mitral annulus is reconstructed and the valve prosthesis is anchored directly into the ventricular muscle, or some like to form a patch and then anchor it into the new valve. So starting here, the valve is excised, the abscess is deprived, irrigated, suctioned, and then you have a very clean ground to place your patch at. You can start attaching your patch at the healthy myocardium in the left ventricle using 5-0 sutures, and then gently pull the patch up towards the left atrium. Some surgeons love to attach it to the superior surface of the left atrium, but some of them like to leave it free and then anchor it with the pleated sutures and then pass the suture into the patch and then onto the prosthetic valve. And the same scenario goes for if the abscess is around the whole annulus. Your patch is going to go all the way around, and then the choice is yours, whether you want to attach it to the left atrium or you want to keep it on the rim. These are the surgeries that I chose for mitral valve infective endocarditis. And right now I'm going to move to the tricuspid valve. So the principle for tricuspid valve infective endocarditis is radical debridement of the vegetation, the infected tissues, and repair is always your first line of choice whenever it's possible. If the valve is largely destroyed, non-repairable, then or if there is a pulmonary pressure and vascular resistance are high, then you're remaining with the replacement. The guideline says that the primary objective for surgery for the right-sided infective endocarditis, that would be radical debridement of the infected vegetations and the foreign material. That's class 1B. Tricuspid repair whenever is possible, that is class also 1B. The technique is the same, happen intra-op, TE is mandatory, and the exposure of choice would be full median sternotomy. As for the exposure, we're going to go through the right atriotomy, and the excision is going to be made from the right atrial appendage, and then you're going to go all the way down till just above the IVC. Your vertical incision should be parallel to the AV groove, and it is believed that this vertical incision has a higher incidence of lowering the incidence of post-operative atrial flutter. Of course, no need to emphasize on the importance of the AV node for the relation of the septal leaflet, the triangle of Koch. This is why the repair is the first line of choice compared to the replacement, because the injury of this conduction system is higher with the replacement rather than the repair. An option that we have here, if we have a vegetation that is confined to one leaflet, in this scenario at the anterior leaflet or at the septal leaflet, and these vegetations are small, they may cause a little bit of leaflet perforation. What you may want to do is that you want to excise, again, the vegetation, irrigate, section, and then place on your patch and then your annuloplasty. If you happen to have I would say dual vegetations at the two leaflets, then excise them both, patch them both, and then apply your annuloplasty. Saline testing is important when you apply your annuloplasty because it helps you identifying the degree of coaptation of the leaflets, as well as minimize the post-operative regurgitation. Typically, we're going to have around 10 to 12 sutures placed around the annulus, starting from the anterior septal commissure, and then you're going to go all the way around clockwise till the posterior septal commissure, and then pass your sutures into the ring, and then start securing it at the first three septal sutures are tied and secured, and then you're going to move on into the anterior septal commissures, have them secured and tied, and then you can do the rest of the sutures. What's going to happen next is that you're going to perform your aortotomy closure using 2 layers. Say we have a vegetation that is confined to the posterior tricuspid leaflet. You're going to excise the vegetation with the leaflet itself. There's an option that you may want to mobilize the anterior and the septal leaflet, fuse them together, and then apply your annuloplasty. It says here that annuloplasty is needed when you do the tricuspid. If there's a tricuspid annulus is dilated, you need the annulus to support the repair and to minimize the recurrence for regurgitation. The last option I have is the tricuspid valve replacement. So you're going to start excising with the anterior leaflet all the way around, leaving around 2 millimeter margin at the septal leaflet because of the anatomy we just highlighted. And then what you may want to do next is that you want to place your pleated sutures at the apex of the triangle Koch to avoid injury of the conduction system, and then pass on your sutures into the prosthetic valve. To secure the suture, the valve around the annulus, you're going to start by placing a pledgeted 2O suture anteriorly, and then with continuous suturing using 2O proline, you're going to secure the valve into the annulus. And that was the tricuspid native infective endocarditis. The last option I'm going to talk about, which is in case if we have a prosthetic valve endocarditis, the guidelines are class 1B if the patient is presented with heart failure and he has a prosthetic valve. Also a class 1A if the patient has an evidence of dehiscence, either by fluoroscopy or echo. Class 1C if the patient presented with an increased obstruction or worsening of the regurgitation. The other class 1C would be having complication of abscess formation. And class 2A, the surgery is reasonable in a patient who has persistent bacteremia or recurrent emboli despite the proper antibiotic therapy given to this patient. The surgery is considered as a redo. So after you perform a median sternotomy, you're going to have to dissect the heart from the surrounding tissue. You want to place your traction sutures on the right side of the epic of the pericardium. Try to avoid the traction sutures on the left side of the pericardium because you want to give your heart the free mobility to slide into the left side as you operate on the right atrium. You want to mobilize the superior and inferior vena cava and free the apex of the heart from any adhesions. Some surgeons love to open the left pleura, and this will help the apex of the heart escape and posteriorly. This is all tricks for better exposure and comfortable field to operate in. So basically what you want to do is that you want to get rid of the prosthetic valve, whether it's around the mitral annulus or the tricuspid, and it should be deprived. All the foreign material, as Dr. Khulud mentioned, has to be removed, including the pledgeted sutures, and any tissue that looks inflamed, edematous, or it may potentially contain any bacterial or infection has to be removed. In some center, they practice having the 10% phenol solution applied on a Q-tip applicator, and then they rub it around the annulus or the cavity. Keep it for a while to as another source to eradicate the bacterial or fungal infection. And then it can be irrigated, suctioned, and then afterwards you're going to place your pledgeted sutures around the annulus and anchor your new valve. So in conclusion, the objectives for surgical intervention for infective endocarditis is to do debridement, remove all the infective tissues and all the foreign materials, general irrigation and suctioning. Surgery is recommended as soon as the surgical indication is established. Thank you so very much.
Thank you, Doctor. I like the pictures, really nice and the clear pictures. Thank you so much.
Welcome, Ayan. Is there any input from Dr. Farid, Dr. Claudio, or Haytham?
Thank you very much. Really, I enjoy the presentation. The picture from which book you bring it, because it was zoomed in. Or which article?
It was from Optic articles.
If you could kindly send it in the group, please. I like especially the picture of the tricuspid valve.
Sure.
In the picture, it was demonstrated that the suture near the septal one, it's taken on the leaflet itself.
Mm-hmm.
The pledgeted.
Yeah. Okay.
Assalamu alaikum.
Dr. Shabir, alaikum assalam wa rahmatullah.
I just joined. I was busy. is almost, she finished the presentation, only last 2 slides. But anyway, what was the topic was what infective endocarditis of right-sided or everything?
It was right side and left side. So mitral and tricuspid.
Okay, so infective endocarditis management. Okay, surgical management.
Yeah. I to say, Mabruk, I enjoyed the presentation. Definitely, yes. Just again, I just want you to notice what was evident from the 2 excellent flowcharts that you showed us. That the surgery is indicated in the mitral as an urgent case whenever you have very large vegetation, which is above 15 millimeters. In between 10, no, it is not urgent. You are just because you are living every day. The vegetation itself that doesn't mean that you have to proceed with urgent, but you need embolic event, you need something else, because you are dealing every day with this kind of problems. Actually, the cardiologists are coming to you because the patient has fever and the vegetation, and they will always tell you the size of the vegetation. That's why I'm pointing out these things. They always pointed out the size of the vegetation, the position of vegetation. And what I prompt you is just do your homeworks and see whether the sites with the kind and the position, because there is evidence that if you have a vegetation on the mitral, especially if the vegetation is coming from Staph Aureus, the indication is much more strict in the mitral position rather than in the aortic position. You're dealing every day with this kind of problems, surgically. And if I'm able, see whether, if I can share with you a picture of how a reconstructed mitral annulus appears. See what I can get from photos. Yeah, thank you very much. Yeah. Yes, that's, can you see that?
No, we still can't see. Yeah, now we can see.
Okay. That's the posterior leaflet reconstruction. This is what you were talking about. And this the actual appearance. It just reminded me, it was on my Facebook since a few years ago. So it's, that's how you have to reconstruct the posterior leaflet with a patch, exactly with the technique you described. Thank you. Thank you for your time.
Dr. Claudio.
Yeah.
So this is, you did a repair here?
No, it was a valve replacement, no way to repair.
Okay. But because of the defect, you put the patch, then on that you did the mitral valve.
The mitral valve, the prosthetic. I do prefer bioprosthesis rather than mechanical when you go for these things. You have less risk of impinging one of the leaflet mechanical valve in your, so a bioprosthesis is always preferable. But these are extreme cases,
Thank you.
Thank you so much, doctor.
Okay, any other comment or question for Afnan? Okay, thank you, everyone. So again,
if you allow me. So Assalamu alaikum. يعطيك العافية دكتور. Thank you, Dr. Afnan. I just have a small comment. So kindly whoever's preparing the presentation, who's in schedule, if you have any condition or you have to cancel the presentation, please, you should arrange for a replacement, because this happened like frequently lately. So please, it's responsibility of the presenter to find a replacement, because we've been not using the all time for the activity. So just kindly, if you have any issue you cannot present, just arrange another with your colleague to for a replacement. That's what I want to say. Thank you, Roy.
Thank you, Faisal. So unfortunately, the next two presenters, they will not be able to present today, so we had to reschedule their presentations. As Faisal mentioned, we have to use our time efficiently, so you need to communicate with us and with someone to fill your position if you are not able to present. So by this, we'll conclude our session for today. Thank you.